Hello, Francis Bezic. I apologise for the lack of the storyboard and graphs or circumstances beyond our control, but I just thought I'd explain some of what we've been doing. The background is, like other people found, there are a whole lot of other things going on in the organisation. The introduction of e-prescribing in particular was huge organisational commitment with individuals and very time-consuming. Like a lot of you, our gut feeling was that the opioid problem was respiratory depression. And so we thought that if we had documentation, it would improve. But on-the-spot audits of the medical and surgical ward of 5 patients a week, we couldn't identify any instances of respiratory depression, which meant we weren't able to document any improvements, which didn't suit Prem very much. We confirmed it on coding reports. When we looked into the coding reports on sedation and respiratory depression, there were sort of 3 main groups. They were episodes of sedation due to severe illness or dying, severe sepsis, and labelled as morphine respiratory depression by a house surgeon or intern, but then it became recognised later that they were very crook patients. Or there were 1 or 2 admitted from the community into ED with rapid escalation of ineffective opioid doses. So we weren't going to be able to change that at this stage. And there are some that were due to co-administration of benzodiazepines, which no one's yet talked about. Successes, we've been using an audit tool which has been helpful. We've found that looking at the reasons why we weren't having the problems, I think it's because we're a small unit. Things like ERAS has been introduced, and our colleagues in Mercy were saying how difficult that would be when they've got 180 anaesthetists and I don't know how many surgeons. We've got anaesthesia consistency, the pain team's highly visible, we don't use inappropriate prescribing, we haven't got high doses, the anaesthetist, we do an audit and it picks up problems early. And I think the eMed chart, although it's so time-consuming and problematical, has actually improved some of the prescribing parameters and practices. So, yes, we've made some small improvements, like the naloxone protocol. We've identified that we haven't got much harm. We hope that it's not hidden away somewhere. And we've got a good team. We haven't introduced, a lot of people have got more other staff involved. We hadn't done that until we'd found something that we could change. How can you encourage people and educate them if there's no change? So we're working on that, and we've learnt a lot from today, and we'll be looking at what we look at next. I just like, I'm a bit naughty, just to mention the elephant in the room. One of the problems with opioids is that we haven't got a lot of alternatives. We haven't got the step 2 analgesics. We've lost our dextropropoxyphene, and Panadol doesn't last more than a few hours, and we haven't got all those buprenorphine patches and lignocaine patches and tapentadol and a low-dose sustained release morphine for the elderly. So I think what we're forgetting here is that Pharmac have a big say in what's actually available, and we just have to get on and use what we've got, but it's one of the reasons there's a slightly bigger problem that there need be. Thank you.